So I am very pleased to have Dr. Haley Burke with us here this evening. She is a favorite of our speakers here in Migraine Relief Code. And so we're going to talk a little bit about injections for migraine. So we wanted to give you a little bit of an overview of what some of those different injections look like, sort of the pros and cons, and just arm you with information so that you can take this to your doctor if you think it might be a good fit for you.
So some of these are procedures that can just be done in clinic, and many neurologists and neurologists who specialize in headache may be able to do these without any extra special equipment. And some of these are called pericranial nerve blocks, peripheral nerve blocks, trigger point injections. And what these are a series of injections that mainly use a numbing medicine, similar to Novocaine. We also call it a nerve blocker medicine. And what it does is when the medicine is given at the site of where that nerve lives, it shuts it down. So it causes numbness, it stops it from signaling any type of pain, it stops even just the sensory component. So instead of feeling light touch, it just feels pretty numb, similar to when you go to the dentist and you're having your teeth worked on. And after that, you can expect to have at least a couple hours of numbness thereafter, where it shouldn't be sore to touch, it'll feel numb. And the idea is that when the medicine wears off, it basically resets the nerve. So nerves that were previously hyperactive, nerves that were previously firing inappropriate pain signals without any ongoing injury to the tissues, it kind of resets them. It's like turning off and on your laptop. And the hope and thought is that when the nerve wakes up, the nerve will be less irritable and less likely to propagate these ongoing pain and headache signals.
So just to clarify here, does the injection actually go into the nerve or is it around the nerve?
Yeah, and that's a great question. And typically, these nerves are very small. So some of them are about the size of dental floss. So even if we tried to put it directly into the nerve, it probably is unlikely to happen. But the idea is to try to get the medication around the nerve. Sometimes if it gets underneath the insulation of the nerve, that's not a harmful thing. But generally we don't inject the nerve itself, the nerve fibers themselves, but the medicine will get absorbed around it.
Okay, great. And then how long do patients get pain relief?
The benefit is so variable among patients. And I have patients who maybe they have this done twice a year and that's all they need, and they live their lives in the meantime and do well. Other times it may be more short-lived, so maybe even a couple days or weeks at a time. And then of course there are people who don't find a benefit from it.
Okay, great. What you got next for us, Dr. Burke?
So those are some that are done in clinic, and there are some others. One that I'll just mention briefly, in part because Jessica brought it up too, and it's an option that I've seen variable success. It's not one that I count on working all the time, but the sphenopalatine blocks. But using a very skinny syringe in clinic, oftentimes we'll have people lean all the way back with their head kind of upside down over a pillow, and then we'll do a couple drops and let the medicine absorb there, and then repeat it in maybe 5 or 10 minutes. So that's not quite an injection per se, but it's a procedure that oftentimes people can even replicate themselves at home. Historically, it's also been done by your doctor soaking Q-tips in some lidocaine or numbing medicine, and then just putting the Q-tips towards the back. But just anecdotally, I've found that doesn't quite work as well.
So it sounds like having a COVID test, except with the anesthesia on it. You know how they go so far back in your nose?
It does. It does. So otherwise, other options that we can think about, particularly in people who haven't responded to other treatments, would be to target the medial branch nerves in the back of the neck. And I'll grab my model right here. Oftentimes, we'll see people that have neck pain associated with their headaches, and they say it's at the base of my skull, it's right where my head meets my neck. And what we know about these top levels is that there's a small branch that comes across and then comes up the back of the head, and that's called the least occipital nerve, or the C2-3 medial branch. And that's a very common structure that we can target for people that have headaches. It generally works the best for people that have pain in the back, but I've also seen people that have pain that radiates forward towards the eye or temple that also may benefit. And with this procedure, it is one that requires a little bit more precision. So it's done under X-ray guidance called fluoroscopy. And the way that it works is that the patient will be lying on their stomach, supported by some pillows, the head tilted slightly to the side, and a couple X-rays will be taken to identify these structures clearly. And at that point, your pain doctor can put a little bit of numbing medicine, just a little skin wheel of lidocaine over the skin that lives right on top of these joints, right on top of that nerve. And after that, a needle can be advanced to block either into the joint itself with a little bit of numbing medicine and a couple drops of steroid, or the third occipital nerve that lives right overlying it and radiates up towards the back. And the idea of these shots is kind of twofold. Of course, we want everyone to feel better afterwards, but we also use them as a diagnostic tool to help determine if these structures may be contributing to the headache patterns.
Okay, so just to be clear, this sounds an awful lot to me like the other injections, with the exception that you need a fluoroscopy machine for x-ray because you're going near the neck and you do not want your needle to go in the wrong place. Is that kind of...
That's right. Well, the good news is that there are some long-acting versions of that treatment that can be pursued. Now, the most common of this is called a radiofrequency ablation, or RFA for short. And the point of that is not just to numb the nerve, not just to stun it and stop it from signaling pain temporarily, but actually using a needle where the tip of the needle heats up. And your pain doctor knows exactly where these nerves live, and the needle can be placed parallel. So I'll turn it to the side. The needle can be placed basically parallel to where that nerve lives and coagulate those nerve fibers. And the point of that is to help prevent them from signaling pain for a longer duration. Typically, we expect to see benefit last at least 6 to 8 months. It's not at all uncommon to have pain relief last years at a time. And eventually these nerves do grow back. It's almost one of the only situations where I wish the body wouldn't heal itself quite so well. But it's one that we consider kind of a semi-permanent type of pain relief.
Okay, so actually the tip of the needle just heats up. It's
That's
not
correct.
like radio waves or, you know, radiation coming into you or anything. Because some people call it like burning the nerve, which sounds kind of scary. Yeah, and I mean, these nerves aren't firing normally anyway. They're firing abnormally to begin with, which is why you're having pain. So you're just kind of shutting down the ones that are, it's like pruning a tree. Yeah, we work on the neck a lot in the yoga that we do in this course. What we do is when everybody shows up on the yoga, we ask what's going on with them that day. There's almost always somebody who's having neck pain. So we do a lot of work on neck pain with yoga.
Oh, I should join next time. I'd love to see that.
Oh, please do. Next Tuesday. I'll send you the link.
Excellent. Excellent.
Yeah. All right. Well, it's a few minutes past 6. I don't want to take up any more of your time. Dr. Burke, thank you so much for joining us today. We really appreciate you sharing your knowledge, your approach to how you heal patients and help patients with migraines. So thank you so much for being here. We really appreciate it. Little high five, everyone. Can we give her a high five on the screen?